on to our next speaker, Dr. Rohit Saxena. You are known to all of us, very enigmatic and endearing, and is leading the Strabismus Pediatrics and Neuro-Ophthalmology Division of RP Center and holding the position of member ARC for the second term without any opposition. Nobody would dare to oppose Rohit. So on to you, Dr. Rohit.
Thank you, Dr. Chitra, and I'll be talking about the current scenario of optic neuritis, which has actually undergone a major change in our understanding. So a little bit about the background. Optic neuritis is essentially inflammation of the optic nerve and could present as papillitis, where there is disc edema, a few vitreous cells, some splinter hemorrhages. The edema is moderate or mild to moderate. It's not very severe like papilledema, or it could also be not there and the nerve could get involved in the retrobulbar part, as in retrobulbar neuritis. It's usually uniocular, predominantly affecting females in the youngish age group. Acute loss of vision over hours to days. It's not immediate or sudden, which is more often or more likely to go towards an ischemic event. The vision loss may even be very subtle and may just present with a mild visual field effect to no PL. And the visual loss would tend to progress a little, would kind of plateau out by second week, and then will start improving gradually with the presence of RAPD in a unilateral case. And of course, the fundus we discussed. The causes could be demyelinating, which is the most common cause with the isolated or with multiple sclerosis, and of course, others like infections and inflammatory lesions. Optic neuritis with multiple sclerosis is what the ONTT had actually commented upon, and our understanding of its association is that optic neuritis presents in 50% of patients with MS during their course of the disease, and it could be the presenting feature in about 20% of patients with multiple sclerosis. And recurrent optic neuritis may be more commonly associated with multiple sclerosis. Now, these were typical features that were kind of described and summarized in the ONTT trial, and anything other than that is actually called an atypical optic neuritis, where it could be absolutely painless vision loss, older patients, bilateral involvement, very severe disc edema, hemorrhages, cottonwool spots, a lot of hemorrhages. Generally, one splinter or a bit is usually there, but a lot of hemorrhages is unlikely. Visual loss continues beyond 2 weeks. They fail to improve with treatment, or else they have multiple recurrent episodes of visual loss with significant drop in visual acuity. So essentially, when we've described typical and atypical, our understanding is that typical optic neuritis could be isolated or MS related, but is demyelinating in etiology. Although rarely other causes could present in a typical manner. Atypical is most likely not due to demyelination, and you must look at all these others like particularly NMO or MOG, autoimmune, prion, infections, particularly in our setting. So atypical, unlikely to be demyelinating, not impossible, but search for the other characters or other causes also. Essential diagnosis is clinical only because of visual loss or fundus appearance, RAPD. Absence of RAPD, unless it's bilateral, be very suspicious of an optic nerve problem. And of course, visual function deficit in the form of fields, color, contrast, visual acuity, and of course, increase in latency of the VAP. As such, for diagnosis, usually, at least in the first episode presenting with this clinical feature, you would not go in for too many investigations for diagnosis. In our setting, we do electrolytes and a chest X-ray because electrolyte imbalances have been precipitated by IV methylprednisolone, and chest X-ray because tuberculosis can flare up, and we've had a couple of cases where the tuberculosis flared up. So just as a precautionary measure. The moment it's an atypical presentation, look for all possible etiologies before you think of demyelinating and start steroids at the first go. MRI brain now, brain and orbits with contrast is almost mandatory in all patients, but because of the cost constraint in some of our patients, it becomes very important. Recurrent optic neuritis, patients keen to know about long-term prognosis with evidence of other neurological involvement, of course, atypical cases, especially if you're thinking in terms of a compressive lesion, and in children. So MRI has become the most important predictor for development of multiple sclerosis over the long term, and white matter lesions that can be seen in the brain, which are specific for multiple sclerosis or suggestive of MS, become highly suggestive that this patient in the long run is going to go on to develop multiple sclerosis. Our understanding really of the optic neuritis disease pathology came from the ONTT, which evaluated placebo versus oral steroids versus IV methylprednisolone over a follow-up of 15 years. And essentially, we learned that IV methylprednisolone provides faster recovery, although finally, long-term, finally at the end of 1 year, there was no significant difference between the three groups. However, oral had a higher recurrence rate, so therefore, oral steroids in the current standard therapy is not acceptable or should not be given. There was a 50% probability of optic neuritis developing multiple sclerosis, and MRI was the most important predictor, and those with no lesions had about 25% chance, and one or more lesions had a 3-time chance of developing multiple sclerosis in the next 15 years or so. And of course, now the recommended treatment is IV methylprednisolone, 1 gram for 3 days, followed by an 11-day oral treatment, although that may not always be essential. Also, depending upon the severity, we are also giving sometimes up to 5 days, especially if it is thought that the patient may have NMO spectrum disorder or there are clinical features suggestive. And we had evaluated dexamethasone as a comparable to methylprednisolone, especially at times when it was not easily accessible or very expensive. And essentially, the final visual acuity attained was similar in both the groups. Can we alter the disease course is something that is a very important question. Over long term, will all patients suffer disabling multiple sclerosis? So we have now disease modifying agents that can be tried and that can be treated, which can reduce the relapse rate by 30% over 2 years. So there are a lot of studies that have proven that the role of disease modifying agents in preventing multiple sclerosis developing in patients presenting with optic neuritis. So we need to discuss with our neurologist and plan the treatment in the long term. In India, we had in the initial early years, early 2000s, we used to find them to be very different, or at least moderately different from the ONTT profile. We had a high incidence of papillitis, bilateral involvement, painless visual loss, poorer visual outcomes, and we were not sure exactly what we are dealing with. And this was the scene with a lot of studies from Asian groups, Singapore, Taiwan, Japan. And over time, we have realized that probably they were the opticospinal form with an NMO positive antibody. The moment NMO antibody test came, we realized that almost 10% of these patients have NMO antibodies, showing that they are probably NMO spectrum disorder, and they were kind of misdiagnosed as multiple sclerosis. And it's very important to diagnose NMO, and of course, Rashmi will be discussing them. Their presentation is different, and their management is very different for the long term. Initial treatment with high dose methylprednisolone, but for the long term, it's important to have immunosuppressive therapy because disease modifying drugs are contraindicated in these patients. Another test is the anti-MOG test or the MOG antibodies, and they also have their initial presentation similar to optic neuritis, but in the long term, their outcomes are different and may require long-term different treatment. So just as a brief final flowchart, an attack of optic neuritis, you do a brain MRI, you give IV methylprednisolone, associated demyelinating agents, discuss with neurologists, consider interferons and disease-modifying agents. Normal, the MRI is normal. You could follow up these patients, a repeat optic neuritis, neurological symptoms, abnormal MRI on follow-up. You again consider disease-modifying agents, no repeat episode, you could continue to follow up. So in conclusion, optic neuritis may be isolated or part of multiple sclerosis. Baseline MRI is essential, helps to predict MS, steroid speed recovery, and disease-modifying agents may reduce the pace moderately and may prevent depth transfer to multiple sclerosis. And the moment you have atypical features, investigate for different causes, consider NMO and more. Thank you for your attention.
Thank you, sir. That was a very informative talk. I have a question for you, sir.
Yeah.
When do you suspect granulomatous pathology in an optic neuritis or an optic neuropathy?
So again, the moment you have any atypical feature, so granulomatous, firstly, of course, the moment you have disc edema, you must do an indirect, because disc edemas are also associated with intermediate uveitis. And we've had patients who would obviously initially respond to steroids and would be thought as, responding as an optic neuritis, but later on come back with recurrence because of intermediate uveitis or posterior uveitis that was missed. So every patient of optic neuritis, dilate and see the fundus. Subsequently, like I said, if the presentations are atypical, you start thinking in terms of, other disorders, particularly inflammatory or one of the uveitis that may be associated in these conditions. Again, another feature which is often kind of misunderstood or misdiagnosed is a juxtapapillary uveitis or juxtapapillary choroiditis. So that also will have severe disc edema with engorged vessels. And the first thought is that it's, optic neuritis. But if you see carefully, the edema, the fluid is much more, it's deeper, the choroid gets involved in your detailed examination of the retina. But then, of course, clinical features are usually often the first signs that will tell you to start thinking of other pathologies.
Other addition I would like to make, I think Rohit has covered everything, but one addition where you would suspect that something else is going on, when you have a very fast, immediate and impressive response to steroids.
Improvement.
If steroids there is a dramatic response on first dose, you know that there is something else going on there.
Can I ask a question to Prem? Prem, do you have a condition where a patient has not responded to the treatment, first attack, MRI negative, markers negative? How do you go about?
So it's dependent on the severity of the vision loss. So I think what you're asking is, will we make a presumption that this patient could have an NMO spectrum disorder?
Exactly.
And are we going to push for a more aggressive therapy like plasmapheresis, plasma exchange? And I would say that in our experience here as a center that attracts a lot of patients who have atypical optic neuritis and in particular NMO spectrum disorder, our threshold for going to Plex is low. And we tend to do it in those patients who have presented with an acuity of 660 or worse, in those patients who perhaps are atypical. They're not white. They are a little bit older. They have some other feature that makes us suspicious. And the MRI negative, that's always a little worrisome, but we have learned, I think, in our experience that we should go with the clinical scenario. And if the patient has not had response to steroid, if sometimes the labs are pending, the serology doesn't come back in time, and there is good evidence now that the faster you initiate the Plex, the more likely the patient is to recover vision in the affected eye. So our threshold for doing that in the right clinical situation is low.
Would you consider an interferon, any DMD in such a situation?
I would definitely want to wait until the serology results come back and do some further investigations, lumbar puncture, looking for other mimickers, before instituting a typical disease-modifying therapy for MS because of the risk, as Rohit spoke to, of worsening an NMO spectrum disorder with a patient like that.
Prem, I think I've asked you, we've discussed this earlier, but would starting IV methylprednisolone make a difference to the serology result significantly if the testing is done at a later stage? Because sometimes patients do come to us having received IV methylprednisolone.
Yeah, that's a great question. I have the impression we don't have good data to say that IV methylprednisolone would decrease the sensitivity of the serologies for NMO or MOG, in the short term at least. Plex, absolutely, because Plex is taking the antibody out of the serum. So that will give you false negative. But with IV steroid, I'm less concerned about that. Sachin, I don't know if you have any direct experience with that or not.
No, I agree. IV steroids per se will not affect in the very short run the results of your serology tests. That being said, I will always repeat the serology twice, 6 months apart if the first one is negative, because you can have false negatives in the early stage. But with plasma exchange or even IVIG, that will affect your serology results because you're clearing the body from these antibodies.